All right, so I am going to be talking about why we need dietary therapies for IBD. So, as you are all aware, the inflammatory bowel diseases are increasing worldwide with the greatest incidence and prevalence in North America and in Europe. The incidence of IBD seems to be increasing, and this is tracking with industrialization, which I think really highlights the importance of environmental factors in the pathogenesis of these diseases. We know that the global burden of IBD is quite large. So these are global diseases. Approximately 5 million individuals are affected worldwide. It's estimated that 0.5% of the population has IBD in highest prevalence regions. And as we previously looked at, the rate in the rise of incidence of IBD is steep. And this is particularly true in newly industrialized countries and even more specifically in adolescents in industrialized countries. It's estimated that, for example, even if the prevalence plateaus at 0.1%, China may have over 1.5 million cases of IBD by 2025. So again, I think really highlighting the burden of these diseases on our societies. Thus far, our therapeutic approach to treating IBD has really focused on immunosuppressive medications, but increasingly, given these environmental risk factors, attention is being placed on the environment, such as the gut microbiome, as well as diet. And the hypothesis here is that perhaps diet-triggered changes in the intestinal microbiome might cause a pro-inflammatory state that precedes the development of IBD. And so should we be focusing on diet and the gut microbiome as opposed to just focusing on the immune system, or perhaps a combination of strategies would be efficacious? So why do we need dietary therapies for IBD? So first, science tells us that something in the lumen of the gut is driving inflammation. We also know that our patients want to know what they should eat. So this is one of the first questions that they ask us, and the information that they're finding on the internet is not consistent, and it's clearly not always evidence-based. We also know that our patients are already changing their diets. And so as providers, we need to be prepared to understand the evidence that's out there and counsel our patients. We also know that even our best therapies are not effective in all patients, and they're associated with risks. So let's start by talking about science and the fact that science tells us that there's something in the lumen of the gut that's driving inflammation. And so to describe this, we'll start with a bit of a historical example. So we've known for many, many years at this point that diversion of the fecal stream can be a treatment for some patients with colonic Crohn's disease. And so essentially, this is when the surgeons bring a loop of bowel to the skin and create a stoma to divert the fecal stream. And this, again, can treat refractory colonic Crohn's disease in particular. So this was a study where 3 patients with Crohn's disease who had undergone an ileocolonic resection with ileocolonic anastomosis had a temporary protective proximal loop ileostomy. And what they did is, following the surgery, they biopsied the small bowel tissue, and histologically, the tissue looked completely normal. And then what they did is they collected the ostomy contents for 8 straight days, and then they reinfused ostomy contents into the distal loop. And so this was a protective loop ileostomy. And when they biopsied the small bowel tissue again after 8 days, what they found was that contact with these intestinal fluids for 8 days induced a focal infiltration of mononuclear cells, eosinophils, and polymorphonuclear cells into the lamina propria that was previously normal tissue. And so what is the major component of our ileal content? So digestive secretions, but also partially digested food. So again, I think raising the question, could something that we're eating be driving the inflammation in inflammatory bowel disease? Let's look at some early life environmental exposures and how these exposures may impact inflammatory bowel disease. It's been hypothesized that breastfeeding may have an impact on the development of IBD, but more recently, there's also been some evidence that perhaps breastfeeding may have an impact on disease behavior. So this was a study that looked at early environmental exposures in the RISK study, which is a pediatric Crohn's disease inception cohort. And in this study, history of breastfeeding was inversely associated with the development of complicated phenotypes. So can diet, and particularly diet early on in life, affect not only disease development, but also perhaps disease behavior? There's also some additional epidemiologic associations between diet and the development of IBD. This was a systematic review that looked at dietary intake pre-IBD diagnosis and risk of developing IBD. And it was identified that high dietary intakes of total fats, polyunsaturated fatty acids, omega-6 fatty acids, and meat were associated with an increased risk of Crohn's disease and ulcerative colitis. High fiber and fruit intakes were associated with a decreased Crohn's disease risk, and high vegetable intake was associated with a decreased ulcerative colitis risk. And then more recently, Ashwin Ananthakrishnan looked at the overall dietary inflammatory potential of the diet. And so in this study, they looked at food frequency questionnaires that were collected prospectively over a several year period of time in 3 large observational cohort studies enrolling healthy adults. And this included the nurses' health studies. And they calculated something called an EDIP score, or an empiric dietary inflammatory pattern score. And this score is a weighted sum of 18 food groups, with higher the sum correlating with a more pro-inflammatory diet. And previously, high EDIP scores have been associated with elevations in several serum inflammatory markers. And so in this study, they had over 4 million person years of follow-up, and there were 328 cases of Crohn's disease and 428 cases of ulcerative colitis. And what they found was that the highest quartile of EDIP score was associated with a 51% increased risk of developing Crohn's disease. Now, interestingly, in this particular study, there were no associations of dietary inflammatory potential with ulcerative colitis. So what can we learn from this and other epidemiologic data? It seems that what, and also potentially when you eat, can influence one's risk of developing IBD. It also seems that it's quite likely that earlier exposure may be more important than dietary changes later in life for the purposes of disease prevention. And so this is the overall way that we have been viewing things for some time now. We know that in IBD patients, there is an abnormal composition of the gut microbes. Multiple studies have demonstrated that diet plays a key role in determining the composition of the gut microbiota. We also have these associations from an epidemiologic perspective between diet and the development of IBD. And so it's logical to think that diet may be involved in the development of IBD and may serve as a potential therapy. And this is what we have seen in the literature, increasingly so in the past decade or so. So I think this really raises the question, could there be something bad in our usual diet that influences the composition of the gut microbiome or gut barrier function and is involved in the pathogenesis of IBD? The table on the left comes from a review, a relatively recent review, which I think really nicely summarizes foods and nutrients that have been shown mostly in animal models to have an impact on gut barrier function. And some of these food components that increase permeability will be familiar, like fructose and dietary emulsifiers, which are both ubiquitous in processed foods and highly prevalent in the Western diet. Again, I think really raising the question, could the Western diet be an environmental trigger for IBD? And this hypothesis has been strengthened by a couple of recent epidemiologic studies that have linked intake of ultra-processed foods to the development of IBD. Ultra-processed foods include most mass-produced foods and beverages. These items contain food additives, such as emulsifiers, preservatives, added sweeteners and flavorings, trans fats, and colorings. So next we'll talk about the fact that our patients really want to know what they should be eating. And this is one of the first questions they ask us when they come into the office. And they're already looking for this information in places where they may not find evidence-based or the most up-to-date recommendations. So these data come from CCFA or IBD Partners, which is an internet-based cohort study of adults with IBD. And in this study, adults with IBD were asked using open-ended questions about foods that they felt either improved or exacerbated symptoms. In this study, for example, patients really across the board, independent of disease subtype, felt that yogurt and rice led to improvements in symptoms. Interestingly, bananas were shown to improve symptoms in patients with ulcerative colitis with a pouch, and a whole host of foods were found to worsen symptoms, as you can see here. And these were generally consistent among disease subtypes. And not surprisingly, patients tended to avoid foods that they felt exacerbated symptoms, creating in essence their own exclusion diet. It's important to recognize that worsening of symptoms does not always equal worsening of inflammation and vice versa. But certainly this has been shown time and time again that patients avoid foods that they feel either exacerbate symptoms or that they worry will lead to a disease exacerbation. So lastly, we really need dietary therapies for IBD because even our best therapies are not effective in all patients and they are associated with risks. This slide shows the biologics and small molecules that have come to market in the past decade or so and the clinical trials that have brought them to market. And when you look at all of these studies, it's interesting that we see about a 50 to 60% rate of clinical response to induction therapy, about 30% clinical remission with induction therapy. And we also see loss of response at a rate of about 15% per year, with 100% risk of disease recurrence, essentially, particularly in Crohn's disease, sometime after treatment is stopped. And so clearly, despite the fact that these medications are effective and really life-changing for many patients, this just is not good enough. And so our rates of remission and response are not good enough. And these medications, we know, do not work for all patients. Similarly, in the pediatric world, we see very similar remission and response rates to what I just showed you in pediatric IBD. And so here you can see data looking at infliximab and adalimumab for induction and maintenance in pediatric IBD. We have seen in the biologic era a decrease, so an improvement in surgical trends in the Crohn's disease population based on population-based studies, but I still think that there is significant room for improvement. It's clear that we can do better. And so I think, again, this really raises the question, if we can treat to target using medications, but also adding in dietary therapies, can we further improve outcomes for our patients and decrease the number of surgeries? Of course, there are also significant safety concerns. There are particularly hematologic malignancies and skin cancers that are associated with the immunomodulators and biologics that we use to treat IBD. And I think this is particularly important in the pediatric population because our patients without a cure for these diseases are potentially going to have a lifetime of disease. And so really thinking about minimizing exposures and minimizing risk of adverse events in our patients is really critical. So again, another reason that dietary therapies are attractive, either as monotherapy or as sole therapy for certain patients who, meet specific criteria and are good candidates for dietary therapy, or as adjunctive therapy, potentially to reduce the amount of medication that we need to use in these patients. Another concept that I'll leave you with is this idea that clearly at the time of IBD diagnosis, the disease has initiated with subclinical inflammation months or even years prior to the time of diagnosis. And so I think that this window is really important and maybe a really interesting window where we should be thinking about prevention. So are there ways that we can use dietary therapy to prevent disease in patients who are at higher risk for developing disease, or if we can identify predictive biomarkers? So to conclude, why do we need dietary therapies in the era of biologics? Because they make sense. We also know that our medications have limited efficacy. They are certainly not a cure. There are safety concerns that, while the medications that we use to treat IBD are overall quite safe, I think that the safety concerns are not insignificant. And again, I think particularly in children who will have a lifetime of treatment ahead of them without a cure for these diseases. So for all of these reasons, I think that we really do need dietary therapies, even in the era of biologics.